Hello, fellow Ambulance Corps, and welcome back to Episode 7, Medical Decision-Making Capacity. I'm Jonathan Barr, and this time I'm going to take you through how to decide whether or not the patient can refuse transport to the hospital. Hey guys, let's just take a moment to review the disclaimer. One thing that's a little different this time, I am going to mention an organization called the National Association of EMS Physicians. Again, this is my own opinions and don't represent the views of that organization either. All right, let's move on. One additional disclaimer that's really important for this particular talk. I'm going to talk about some legal concepts, but I'm a doctor. I'm not a lawyer. Okay, I'm going to talk about the medical assessment of capacity, but nothing I say should be official legal advice or substitute the advice of a lawyer. All right, before we get into it this time, I just want to tell you guys about something. So I recently just came back from the National Association of EMS Physicians Conference, and I just want to make you guys aware of NAMSP because this is an organization you can actually get more involved in as well. So this is the professional society for physicians who are involved in EMS in some way. This society also creates national clinical guidelines for EMS care. They set the criteria for EMS fellowship training. Many of the people who make the NREMT course also attend this, so that's a separate national organization, but EMS is a small world, so many of the same folks are at both places. And you can come to this conference as an EMT, and you can get continuing education credit. You can also meet a lot of other people. You can hear some interesting research. You can take some interesting classes. And if you're interested in getting more involved in it, you can let me know, and I can help connect you. I don't have any financial stake in NAMSP. I don't get paid extra if you join or you don't join. So it's just a cool organization you could be a part of if you really want to get more into the field. It also was the inspiration for this talk because I had done a little research work on medical decision-making capacity, and one of my colleagues actually presented my work at this conference nationally last week. And so I thought it would be a good thing to talk to you guys about because this is one of the single most important things we do in EMS, and I'm about to tell you why. So why do assessments of medical decision-making capacity matter? Well, they matter because if we go back to 1891, the U.S. Supreme Court ruled that an individual cannot be compelled to submit to physical examination. Subsequently, common law established the principle of bodily integrity as a constitutional right. What that means is, as a patient, you have the right to control what happens to your body. Okay? So patients have certain rights, and if you violate them, such as if you take someone against their will to the hospital, you're potentially on the hook for assault, battery, or even wrongful imprisonment. On the flip side, however, if you leave someone behind, meaning you let them refuse medical attention or do an RMA, and they didn't have medical decision-making capacity, you're potentially on the hook for negligence or abandonment. And so you really have to thread a needle with this. And don't think the lawsuit can't happen to you. This is actually the most common litigated thing in EMS. EMTs, firefighters, paramedics, even the medical director has been implicated in some of these cases. And so it's really important that we're really good at this to avoid bad outcome for the patient and also to avoid any consequences for yourself, because this is a dangerous kind of area. You know, like I said, it's a dangerous area, and if you make mistakes, you can end up either in jail or you can end up with civil fines or court fees. You know, up to 50 to 90% of the lawsuits in EMS have something to do with capacity. So it's really common sorts of litigation and something we really need to do well. Now, how good are EMS providers, such as EMTs and paramedics, at assessing decisional capacity? Well, the interesting thing is it's not really known. This is something that's very hard to study, and which is why I tried to study it in my work that was presented at the conference. But one way other people have studied it is they look indirectly. They look at what are called bounce backs. These are people who refused medical attention with EMS, but then then go back to healthcare within 48 hours. So either calling back 911 or going to the ER. And so that's actually, unfortunately, really common. So patients who refuse going to the hospital often end up in the hospital anyway within 2 days. Okay? And, this isn't all about EMS providers. It turns out that physicians aren't good at this either. In one review paper of physician ability to assess capacity, they only recognize the patient not having capacity 42% of the time. And so physicians are often getting this wrong as well. And so if we take those three things together, that the patients have kind of constitutional rights to autonomy and bodily integrity, and if we inadvertently violate them, we face consequences. And if you combine that with the fact that medical providers are not that good at capacity assessments, that really puts us in a danger zone, because we're at risk of inadvertently harming people and inadvertently getting ourselves in trouble. And so that's why we're talking about it now. So I've been throwing around this term capacity for a while now. What does it actually mean? So to understand decision-making capacity, we need to understand these three things. Capacity is the foundation for informed consent and legal competence, okay? So to understand the differences between these terms, let's start at the top of the pyramid. So competence is a legal determination, okay? Capacity is a medical assessment, okay? And consent is capacity plus the ability to be free from coercion and understand the risks and benefits after being given adequate information, okay? So if you are legally incompetent to make decisions, you can't make decisions for yourself. So how does that matter for you in EMS? So if you encounter a minor, like a 10-year-old is legally incompetent. 10-year-old cannot make decisions for themselves, okay? If you encounter an adult, are they legally competent? The answer is you can't call a judge in the middle of your call to find out. So EMS has to operate under the presumption of legal competence for adults. Okay, there are certain exceptions where a patient may present papers, where they might have some kind of paper that deems them incompetent if they have certain conditions. But for the most part, most adults have a presumption of legal competence. Okay? So if we presume legal competence, then the question becomes, can they provide informed consent for treatment or informed refusal to not get treatment? And in order to determine if they can consent, we have to medically assess their capacity to do so. Okay? So let me summarize it again, because people get confused with this easily. Competence is a legal determination. EMS operates under a presumption of legal competence for adults, because we can't call a judge in the middle of a scene, right? It's not feasible. Capacity is a medical assessment. If you have capacity and are free of coercion and understand the risks and benefits of what you're doing, you can provide consent or informed refusal as well. Okay? And if you're a minor, for example, you're legally incompetent, it doesn't matter the whole rest of this. You're legally incompetent. You can't do it. Okay? There are a few exceptions to that with emancipation, but by and large, competence mostly comes into play with minors for EMS providers. Okay? Because capacity is the medical assessment and is the foundation of this, because if you don't have capacity, you can't provide consent, you can't be competent. Okay? If you don't have capacity, you can't provide consent or refuse, and you can't be considered competent. Okay? Because that's the medical assessment, that's what I want to focus on. So what is capacity specifically? Unfortunately, there's a lot of different definitions, and so the one I'm going to give to you now is the one that's put out by the National Association of State EMS Officials, also called NASEMSO, and they produce a national model clinical guideline, and they define capacity as follows. So it's any individual who is alert and oriented, okay? We're actually really good at that. EMS providers love to do that part. And also has the ability to understand the circumstances surrounding his or her illness or impairment. They have to understand the circumstances, okay? Another way to say it is they have to appreciate the situation around them. They also have to understand the possible risks associated with refusing treatment and/or transport. And if you're alert and oriented, so you need an orientation component, you need to be able to understand or appreciate the circumstances around your illness and understand the risks, then you typically have capacity, unless you're impaired, either by drugs, alcohol, or by your illness or injury. So some common examples would be hypoglycemia, alcohol intoxication, a head injury might impair you. Additionally, individuals who have attempted suicide, verbalized suicidal intent, or here's the key part, have other factors that lead EMS to suspect suicidal intent. Okay? Police officer told you they made a suicidal statement, for example. If they have other factors that lead you to suspect suicidal intent, then they cannot be regarded as having decision-making capacity and cannot decline transport to a medical facility. Okay? So let's take a look at a couple more elements of this. So I mentioned that Necemso is one definition. These are some of the other components that are part of capacity that I pull from other definitions. So the patient must understand the relevant information about the proposed diagnostic test or treatment. So the patient has to understand what you're asking them to do. If you're asking them to go to the hospital or whatever it is. Or it might just be you're asking to examine their lungs. That's a diagnostic test that you do as EMS, is you examine patients, right? The patient has to appreciate the situation, okay? They have to understand the circumstances of what's going on. They have to understand the severity of what's going on, and you have to explain it to them. They also have to use reason to make a decision. That's an important point. So when you decide you want to refuse to go to the hospital, you have to say some kind of reason why you don't. And as an EMS provider, you don't have to agree with the reason, but you have to be able to follow the patient's logic. You have to understand what they're saying. Like, it has to make sense to you. And I'll get into a little bit more about what that means in a minute. The patient also has to communicate a choice, right? If they don't tell you they don't want to go, then they kind of can't have capacity, right? They have to communicate their decision. If they can't communicate the decision, you can't have capacity. Now, that doesn't necessarily have to be verbal. Maybe they could write it for you, okay? Sometimes verbal is not an option, but they have to be able to communicate the choice to you in some way, and the patient also cannot be a minor. Or if they are a minor, they have to be emancipated, okay? Here's something that gets thrown at me all the time. I've talked to many EMTs and paramedics, and I hear this statement. But doc, he's answering all the questions. I'm going to put that in air quotes. Answering all the questions. One, I have no idea what that means. Are you trying to tell me that he's alert and oriented ×3? That he's answering questions in a logical way? That he's showing reasoning? I'm not sure what that means, answering all the questions. But then the last part, where people were to say, I'm not going to kidnap him. I want you to get the idea. You're not kidnapping people, okay? If a patient doesn't have capacity and you take them to the hospital, it's not kidnapping, okay? If they don't have capacity, they have to go to the hospital, okay? So it's not kidnapping. Don't worry about kidnapping. If you're making good capacity assessment, you're not in this situation, okay? So let's go through some other common kind of concepts and pitfalls here. So one of the most common pitfalls I hear, and this harkens back to the previous slide a little bit, is people think if you could say your name and the date and where you are, you have capacity and you can refuse. It's not true. Not true. Myth. Okay? Being oriented does not give you capacity. You need to be oriented in general. There are some exceptions, but in general, you need to be oriented to be able to understand the risks and benefits to be able to have capacity. Okay, but it's not sufficient in and of itself. So just because someone can tell you their name and the date and what's going on, that doesn't automatically give them capacity. They need to be able to understand the risks and benefits of what's going on. Okay? And this has come up. Like, I've had patients who have been intoxicated and trying to see if they're, quote, clinically intoxicated or too intoxicated to refuse, and they'll give you the name, they'll give you the date, and then when you start talking to them, they start going off the rails a little bit, and they clearly can't understand the risks and benefits of what they're doing. So this happens a lot, and so it's important nuance here. The other tricky thing about capacity is that it's a spectrum. So there are people who have no capacity, there are people who have full capacity, and there are people who they may have capacity enough to make simple decisions, but they may not have capacity to make more complicated decisions. And so this can get really challenging. There are people who have capacity to decide about taking a medicine, but don't have capacity to decide on a major surgery for themselves. And so you really have to take this on a case-by-case basis. You have to really see, does the patient understand the risks and benefits of what I'm talking to them about? And most common for EMS, that's going to be refusing transport to the hospital. That's the single most common way this comes up, okay? Now, here's the other key point about capacity is it changes. So you could be really intoxicated and drunk, and then as you sober up, you could regain capacity. So that's something that can happen. Okay, so just because you don't have capacity today doesn't mean you're automatically saying this patient never has capacity. It's just they don't have capacity right this second. Okay, and in that vein, capacity can be optimized. So if someone has a drug overdose and you give them Narcan and they wake up, they could regain their capacity, and they may be able to make medical decisions at that point. You also, there's a bag of D10 there, which you might use to correct hypoglycemia. If you correct that, the patient might also regain their capacity, okay? So because of the challenges involved in this, I've created this is my little 4-step algorithm to try to help you be able to assess capacity quickly in the field. And so we start at the top. I think the easiest way is, one, just look for anything that automatically disqualifies them for have capacity. Because once they have one of those things, you're done. You know what you need to do. Okay? So if they're a minor, gotta go. Unless they're emancipated or their family refuses for them, right? So if they're clinically intoxicated, and that can sometimes be challenging, but clinical intoxication means like when you assess them, you think, yes, they are drunk. If you can't tell that they're drunk, they may not necessarily be too intoxicated. But you also have to think about the specific situation. A common pitfall of this is I read a lot of charge means providers after motor vehicle accident, and the patient, it writes in their chart. I'll see something in the chart like patient admits to having several drinks, patient crashed into telephone pole, patient alert and oriented ×3, does not want to go to the hospital, refusal. Think about what you're saying there. You're saying they admitted to drinking alcohol, they crashed into something while drinking alcohol, but yet they're not intoxicated. You're saying they're not clinically intoxicated. So it has to be consistent, and so this can get quite challenging. But in any case, it's clinical intoxication. If you had one beer and twist your ankle on the sidewalk and you don't appear drunk at all, and you would never even know that they had a beer except the fact that you asked them, that person is probably not clinically intoxicated. And so there's a little bit of provider judgment in that one. Do they have SI or HI? If they do, very easy, they don't have capacity. And is the patient unable or unwilling to communicate? If they can't communicate a choice, you can't have capacity, okay? Next, do they understand the risks and benefits? Okay, this is actually probably the hardest part, the pitfall. Okay, you need to explain it to them. Then they need to be able to repeat it back to you. And I'll talk about this in a minute, about the language of how to do this, because we oftentimes just say, oh, if you don't go to the hospital, you're going to die. That's not really enough. So I'll talk a little bit more about that on the next slide. After you've explained the risks and benefits and confirmed that the patient can in fact understand the benefits, you need to check, are they making choices based on reason? And you don't have to agree with their reasons, but they have to have some kind of logical point A to point B reason that you have to be able to follow. Okay? So to give you an example of what I mean by that is, someone might say, someone with chest pain, you might say, hey, I'm worried that you could be having a heart attack. If you are having a heart attack, you could actually have permanent disability or death from that. I really think you need to be evaluated for a doctor to see if you need further diagnostic testing or treatment, and that can be done at the emergency room. The risk of refusing transport is that you could progress in your condition and you could die from it. Do you understand? They say, yes, I understand that I might be having a heart attack. I understand that I could die from it, but I need to go take care of my dog. They gave you a reason, right? They said they need to take care of the dog. Now, you might think that the dog is not worth having a heart attack and dying, or you might think, well, if you die, you can't take care of the dog. But you could follow the patient had a linear thought process. They gave you a reason you could follow, like, okay, yep, maybe this person really loves their dog. They're willing to sacrifice their own health for the dog. So a person could choose that. They could potentially choose that. They can make a choice based on that reason. You don't have to agree with it, but it's based on a reason. And they say, if you ask them, why don't you want to go to the hospital today? Most people in your situation will go to the hospital and say, well, it's sky's blue today, so I don't really feel like going. You can't really connect that to how that relates to going to the hospital. Okay? So if you can't follow a clear reasoning pattern, the patient doesn't have capacity. And then lastly, if you decide they do have capacity and they're going to refuse, tell them they can come back. Tell them they can call back. Tell them they can seek care in other ways. Give them any guidance on any other symptoms that they should watch out for, things that they should come back for, okay? Tell them if anything gets worse, please come back, okay? Because that's just the best thing you can do in that situation if the patient ultimately still wants to refuse. Let's talk about the language a little bit more. So let's say you have someone who falls, they hit their head, and they're on blood thinners. What I hear a lot of times when I watch calls is they say, they're like, oh, well, if you refuse going, you could die. That's really not enough. You instead might want to say something like, hey, you hit your head and you're on a medication that increases the risk of bleeding. I'm concerned that given you have a headache, you could have bleeding around your brain, and I think you need a CT scan to check for that. If you don't go to the hospital and get that, the bleeding could get worse, which could result in disability or death. Then you can ask them to repeat it back to you. Now, that's one way you could go about this. Now, you might say, well, John, I'm an EMT. I don't know the risks and benefits of every single thing there is. That maybe as a physician you could do that, but how am I supposed to do that as an EMT? Well, as an EMT, whenever you don't know, and you should never lie, you should never make anything up, but whenever you don't know, you can say something like this and say, hey, I think you need to be evaluated by a doctor who can assess you to determine if you have a life-threatening condition. Without a physician assessment, it's possible that you have an underlying life-threatening condition that could lead to permanent disability or death. I really think you need to go to the hospital to be evaluated by a doctor. Okay, that's your way out. When you don't know, you just say, look, I don't know. You need to be evaluated by a doctor. And the doctor will determine if you have a life-threatening condition or not, because that's our job in the emergency room. Okay, so you can say something like that. Okay, so let's get into a couple cases just to try to illustrate some of the points here. And these are all somewhat challenging gray area type cases. And this is really hard. And on a real call, if you get stuck, you can always call supervisor. You can call medical command, and they can help you. Okay? So in this case, adult female calls police, house gets broken into. She made a statement to the police that she's so upset that she wants to jump off a bridge. When EMS gets there, she's denying this. She's alert and oriented, has normal vitals, saying she doesn't want to go to the hospital. What do you do now? So I'm going to give you a moment to think about it. All right, so let's work through it using kind of those steps that I gave you. So step one, does she have any disqualifiers? Well, she's an adult. She's not under 18, so that's good. Does she have clinical intoxication? No, not based on this problem. Okay, let's keep going down. Does she have SI or HI? Well, she made a statement to police that she potentially had suicidal ideation. And remember, the NASEMSO definition says if there's anything that makes the provider reasonably suspect that there could be suicidal intent, you don't have capacity. So to me, knowing nothing else about the situation, I would say that's probably sufficient to take this patient to the hospital. And what will happen at the hospital is they'll be evaluated by an ER doctor and probably a psychiatrist as well, who'll determine, who'll basically do a suicide risk assessment and see if they're safe to leave or not. So probably that's the safest, most conservative way to do this, okay? Otherwise, if they're still trying to refuse and it looks like the situation is getting out of control, you can try to speak to medical command, have a physician talk to them over the phone. But at the EMT level, I think your safest course of action here, given that there's enough maybe to give a reasonable suspicion that this patient needs help, is to take this patient in. They don't have capacity, okay? And you would be justified in doing that. And there are a number of reasons here why this patient might be at risk for self-harm. We mentioned she had a recent stressor in that her house was broken into. And we don't know her background, if she has depression or anything, but that could certainly be a stressful event that could make people, especially if she has nowhere to stay now or something like that. So I think this is risky enough that this patient should be seen by a doc. Okay? So let's talk about this case. So this case, an adult male found down, pinpoint pupils, gets ventilated, Narcan, wakes up, now wants to refuse. What do we do here? So think about it for a minute. So remember I talked about before that capacity can be optimized. This case really illustrates that you can optimize whether or not the person has capacity by certain interventions, by giving Narcan in this case. Now, if we're going to counsel this patient on how to, if they want to refuse, what do we need to tell them? So some things are concerning to me here in that they're tachycardic, hypertensive, and diaphoretic. Now, maybe that's from opioid withdrawal, from getting reversed, or maybe it's from something else. And you won't be able to know that on scene. And so what you might say is, sir, you had a life-threatening overdose. You were given Narcan and bag mask ventilation to reverse it. However, the Narcan could wear off and you could become unresponsive again and stop breathing, which could lead you to die or to have brain damage and be permanently disabled from lack of oxygen to your brain. We'd recommend you go to the hospital to be monitored and evaluated by a physician. We also note that your heart rate's pretty high and you look pretty sweaty right now, so there could be another medical condition going on, or you may be withdrawing, in which case you would still need evaluation by a physician. We'd recommend that you go to the hospital. Would you agree to that? Something like that is what you could say. And if they say no, well, then you ask them to, speak it back to you. Okay? All right, let's get into this one. 15-year-old now, crashes his bike. He's got some abrasions, looks well, no complaints, vitals normal, no parents there. What do you do? Well, if you go by purist capacity assessment, he's a minor, legally incompetent, cannot have capacity, can't refuse. Could you try to call the parents and get the parents to come to the scene? Yeah, that you could try to do that. Maybe you could get a guardian who could refuse for him. Otherwise, you're stuck here, right? You need to somehow get in contact with a guardian who can make decisions for this guy. All right. So let's go through this one. You're called by PD after responding to a domestic abuse case. Patient is female, in her 40s, erratic, agitated, shouting, unable to answer questions or hold the conversation. She's throwing stuff out of the house onto the street, and there's possible weapons in the house, and the patient's locked herself inside. What do you do here? Well, one, in this case, you have a scene safety issue, so you're going to need police to secure the weapons and secure the house. And if you have someone who's agitated, yelling and shouting and unable to hold a conversation, can they have capacity? Can they reason? Can they understand risks and benefits? Odds are no, this patient's not going to have capacity in that moment, unless there's something you can easily fix or correct. Okay. All right. Let's look at this one here. Elderly male at home, denies any complaints. You were called for a psych. When you get there, he says he doesn't know why you're called. Police says there were gunshots at the house. The patient says he's fine. And when you start asking him, he says, yeah, actually he saw some people in the woods outside his house and was shooting his shotgun at them. What do you do here? So is this guy a minor? No, he's an elderly male. Does he have SI or HI? I don't know if you would consider this HI if he's firing at people in the woods, but in this particular case, this was more of a hallucination type situation. He had hallucinated the people there, so that's concerning. Is he a threat to self or others? Is he a threat to others? Yeah, I mean, he's shooting his gun at what he thinks are people, right? And so the point I want to make with this case is that even though this guy is oriented, he doesn't have capacity. He's a threat to others right now. He's having, unusual psych disturbances with these hallucinations, and so this guy doesn't have capacity either. He's going to need to come in. All right. Here's another tricky one. Elderly male at a bowling alley, slip and fall, hits his head, scalp hematoma, had 2 beers, and is on Eliquis. Now what do you do? So he's not a minor. He does potentially have a head injury, although they're telling us in the prompt here that he's got a normal exam and normal vitals and no deficits, so maybe it's just a frontal hematoma. But he is on Eliquis, so he's at risk for delayed bleed. Eliquis is a blood thinner, in case you're not familiar. He's at risk for delayed bleeding, so this is a high-risk situation, right? And he says he had 2 beers. So the question is, does his head injury or do the 2 beers invalidate him? And this is a common scenario. I find it all the time. The alcohol leading to some type of head injury, very common, very challenging, right? And it's a case-by-case basis. So we'd have to talk to him and see, does he understand the risks and benefits? Is he making a choice based on a reason? So, for example, let's say the conversation goes like this. Say, sir, we see that you fall and you hurt your head. We understand you're on a blood thinner. You also have drank some alcohol, so you might not feel as much pain now. Because of this, we're worried that you could have a serious problem, such as bleeding into your brain. And the only way for us to know that is for you to come to the hospital and get a CT scan. Or you could say, the only way for us to know that is for you to go to the hospital and be evaluated by a physician who will determine if you need further testing or treatment. Okay, and let's say he says, yes, I understand I should be seen by, excuse me. Yes, I understand that, but you should be seen by a doctor. He says, yes, I understand I should be seen by a doctor, but I'm 98 years old. I understand that I'm old, and if I die from this, I accept the fact that I die from this. I don't want to spend any more of my time in hospitals, and so I really would rather refuse, right? So he's making a choice based on a reason there. He's telling you that he's old enough that he wants to spend his life outside the hospital, and he understands that if he dies from this, he dies from this. Okay, so people can make that choice, right? A lot of elderly folks would rather stay at home and not be in hospitals, and so they can make that decision. Now, if he's starts slurring his speech and acting wobbly and can't stand up, then you might think, yeah, he's more drunk. Okay, so you really have to kind of assess that intoxication level, and see. And I find it when you're assessing people and you're trying to figure out if they're intoxicated or not, the longer you have a conversation with them, the more likely it is that it's going to come out, meaning that the intoxication is going to manifest itself. The more questions you ask them, the more you get into it, then you start to see them derail a little bit, and you know that they're too intoxicated. Okay, but drunk plus head injury, very common, very challenging, case-by-case basis. You really have to assess the amount of alcohol, how long it's been, what are their neuro exam, what are they doing, and when in doubt, you can always call medical command. Okay? All right, so let's get into the next case. So now you have an adult female, paraplegic, in a wheelchair with a chronic Foley. Family calls, she's confused, febrile, recent had a UTI with sepsis, she's awake, can't answer questions appropriately. So what do we do here? So let's think about this. We've got an adult patient, no SIHI, okay? She seems to be alert and oriented, but she really can't understand the risks and benefits. So she's going to fail our capacity test there. But she is communicating a choice by physically resisting transport, and so making it hard for you to move her. So what are you going to do in this situation? So in this situation, we determine she doesn't have capacity, and so we'll need to find a way to get her to the hospital, and that might involve restraints, that might involve sedating medications by calling ALS. But from a capacity perspective, if she can't understand the risks and benefits, even though she's oriented, she would still not have capacity. Okay, so that's the key point of this case, is that orientation does not equal capacity. And so with that, I'll leave you guys with the references here. Now, I do want to also mention one other thing before I sign off here, is that I've given you a talk today on the academic aspects of capacity. Okay, this is how you would do it kind of by the book, by checking orientation, by checking SIHI, by checking risks and benefits, by checking reason, by checking choice. All that's kind of a very academic way to look at it. The practical reality of capacity assessments can often be a lot grayer, and there may be patients in whom you may determine they didn't have capacity, but you're physically unable to take them to the hospital, or perhaps they fled the scene and ran away, and I mean, you're not going to chase them down. So those cases, are beyond the scope of this talk, and if you want, we can have a case-by-case discussion on some examples of when that might happen. But in general, if a patient is trying to refuse going to the hospital, you should assess their capacity to do so, which is a medical assessment. And if they have capacity, then they can complete the refusal. And if they don't, in general, they should go to the hospital unless there are extenuating circumstances. Overall, I hope this is helpful. I hope it at least is thought-provoking. If there's any things that you're still concerned or confused about, please reach out to me, and I'm happy to discuss it offline. Thanks, guys. See you on the next one.